Kiran sir, can you start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are into the fourth week of disseminating the National Operational Guidelines for ART Services 2021. Today's topic is ART Services for Special Population, and the speakers are Dr. Chinmay Das and Dr. Sudhir Chawla. Dr. Chinmay Das won't be joining us today. We have in her place Dr. Purnima. Dr. Purnima is the consultant with NACO, and Dr. Sudhir Chawla is working as a public health specialist with CDC India. We welcome you both for today's session and request you to start the session. Dr. Purnima, please.
Yeah, thank you. Thank you so much, Shweta, and very good afternoon to everyone. Thank you for joining us in this very important session on ART services for special population. So, and thank you, Dr. Sudhir Chawla, sir, for he'll be taking the session further. I'll just give a brief background of what this session covers and why it is important. So this is a new chapter which has been included under the revised operational guidelines for ART services. As we all know that the key population, which include FSW, MSM, TG, and people who inject drugs, they are disproportionately affected with HIV, and they may or may not access the HIV treatment services like the general population. So they need special focus in terms of providing them services and for providing them stigma-free environment so that they can freely access the HIV services and we can improve the quality of life. So this session will broadly cover and we'll understand how to provide services to this special group and how to register them at the ART centers with the support of various stakeholders like TI targeted interventions, which are working in this field, NGO partners, and other stakeholders like DAPCO, care support centers, and OST centers as well. So when we talk about this population, it also includes sensitization of our staff at the ART centers as well as the TI staff in terms of what is ART, how to start ART and why it is important, as well as the importance of adherence, treatment, adherence, ART initiation, then retention in care, and how to track the LFUs. So this all will be covered during this session. Plus, we also have this very important population, which is migrant. And because, as the name suggests, they are mobile and they move from one place to another. Therefore, the services which we provide them in terms of providing them ART treatment may differ, and we need to understand what is their mobility pattern and how do we ensure them in the ART care. So, and also about the HIV positive pregnant women, HIV exposed infants, and as we all know that HIV exposed infants are given ARV prophylaxis based on their risk categorization of the mother, the mother who delivered exposed the infant is exposed to the HIV positive mother. So these are the special group of population which this chapter covers and talks about how to provide the services to this population. So with this brief background, I hand it over to Dr. Sudhir for a more detailed discussion and sensitization on these areas. So over to you, Dr. Sudhir.
Thank you, Dr. Purnima, and thank you, iTech team and NACO for giving me this opportunity. So as Dr. Purnima has shared, like today we will be discussing some special population and ART service delivery for them, why it is important. So that we will discuss. Dr. Purnima has described the population groups which we are going to discuss. So I'm not wasting much time on that. So we will initiate our session for ART services of special population groups. So as Dr. Purnima mentioned, there are key population groups, like we know, like in India, epidemic is concentrated, and the key population groups are like disproportionately affected by the HIV. So these are like female sex workers, men having sex with men, transgenders, and people who inject drugs. So the PLHIV belonging to any of these KP group are like at risk of getting infection, and National AIDS Control Program is committed to provide quality services at the ART center in stigma and discrimination-free environment and to prevent the loss to follow up in these particular groups. We will discuss about these groups and their challenges and their special needs and how ART Center can support them. So as we know, like most of the key population group members, they are being registered with either TI or the non-TI NGOs for their prevention service package delivery. So they must be in contact with any of the NGO working in this field. So once the person is like referred from TI or non-TI NGO to the ICTC for the testing, so it is the like responsibility of TI and ICTC both to provide sort of background information about the HIV testing, and then once the person turned out positive, then the services which are being offered through the ART Center, and what is the process of like providing services from the ART Center. So that information will be provided by the TI or the non-TI NGO where the person is registered with, and the ICTCs. So for that, it is recommended that accompanied referral services should be provided from the TI or non-TI NGOs where the person is registered. So the benefit of providing accompanied referral is number one is, as we know, like there are different KP groups are having different sort of challenges. So there is a risk of like linkage loss between ICTC and ART Center. So if the accompanied referral is provided from TI, that risk will get minimized, number one. And the second important point is, like as I said before, like person is already registered with TI. So TI staff, peer educator or the peer counselor at TI site, having some rapport with the KP client, will be in position to support ART counselors, ICTC counselor in understanding the key challenges or key like top level issues which the particular person is facing, or the concerns from the person. It may be different for the KP group, like female sex workers may have their own concerns which may be like different from the MSM or the TG population. Within the female sex worker group, also individual level differences may be there, like one female sex worker is working from the brothel and one is home-based sex worker. So both may have their own set of challenges and own set of concerns. So those may have been shared with the TI side before reaching at the ICTC. And TI person is like the right person to share the concerns and to provide the solution. So that's why the accompanied referral in these cases is very important. So and other thing is, once the ICTC testing is done, person is found as HIV positive, then person need to be like registered with the ART Center. So at the time of registration, ART counselor need to build rapport with the KPPL HIV, make them comfortable, make them realize like the confidentiality is the utmost priority at the center. So we will be taking care of that confidentiality, not only for the HIV status, but also for their KP status as well. If they do not want to disclose their status as a key population group member, that will also be taken care by the facility staff. That need to be ensured to them. And then there is something like when the key population group member enters at the ART Center, within the waiting area, they feel sometimes very embarrassing conditions because people are like looking at them and they may feel like uncomfortable while waiting in the at the ART Center. So for that thing, I think we need to sensitize our staff working at the facility as well as the other PLHIVs who are like visiting the ART Center regarding the how to behave with the key population group, consider them as a normal person as others. So that level of sensitization need to be done by the ART Center, and a counseling facility with the audio-visual privacy need to be provided. Similarly, there is a potential risk of migration linked with the key population group members, so that so once we have developed a sort of rapport with them, having person is having confidence in us, then we can start asking about their current address and their native address or their permanent address and the phone number or their relative or caregiver's contact details. Considering the fact like we need to make them comfortable, like why we are collecting this much information. It should not be like feel like something more is demanded from the facility. So that need to be clear to them. Like we are asking this detail because we want to help you in case you are shifting at some other place. We will be able to support you for continuing your medicine. So that sort of information need to be provided. There are peer navigators. There are other staff who can provide accompanied referral, outreach workers, and other staff working at NGOs, TI and non-TI NGO, those who can like support for the counseling and for the day-to-day work, coordination related work with the ICTC and ART center. So now, if the ART is initiated, they're continuing their ART, maintaining their adherence. It's not like the job of only the ART staff. It's the equal responsibility of the TI staff as well, because person was first registered with the TI, so they are having much better rapport with the client. So they will be in the better position to counsel the client for the ART adherence and to understand their barriers to adherence. And at the ART center, it is the responsibility of ART center to understand the concerns and to as per like current technical guidelines, we need to like rule out the any major active OI. If there is no active OI like through the ruling out procedure as per the standard protocol, we can consider them for the rapid ART initiation. And if they are eligible for CPT or the TB preventive therapy, that also need to be considered for the timely initiation, so that the time can be saved, because there are major concerns which we are like from our experience we understand, like key population group members, they feel like they are the facilities are not KP friendly. They are not getting support as and when they need. Timings are not appropriate. So there is a long queue and they're not feeling comfortable. Those are the key challenges which sometimes key population group members have shared during our community consultations. So those things we need to take care and try to understand individual level concerns and provide solution to them. The messages around why ART need to be initiated early, why the rapid ART initiation is important, why adherence need to be maintained, and what are the implications on their health about the positive living and the positive prevention, and U is equal to U messages. Then if they're like from the injecting drug user group, then harm reduction services, oral substitution therapy, OST services, then regular medical checkup. What is the importance of family testing, their partner testing, and children testing. So that need to be discussed in detail. It may not be the job of one person at ICTC or ART. It's a joint responsibility of everyone, like TI, ICTC, and ART center staff. So everyone need to share their responsibility and pass the same messages on as and when they contact the key population group members. There are around 46, 47 slides. I will be trying to complete this within 1 hour. So, if you feel like I'm going too fast, please let me know so that I can reduce my pace. So that was about what I was discussing, was about the retention and how we can. So tracking and loss to follow is the work. Tracking of loss to follow people is the work given to the ART and care and support centers. But in case of KPs, it will be good if we work in close coordination with the TI or the non-TI NGO where the person was actually registered. So they will be able to support you for tracking these clients. That division of work can be done at the level of DAPU. Some of the people can be tracked by the TI staff. So this we discussed okay. So we were discussing about the loss to follow tracking. So data manager. As I was saying, it's a shared responsibility. So at the ART center, data manager can prepare the line list of which LFU are eligible but not initiated on ART. That line list can be shared with the ART counselor, and then ART counselor will telephonically reach out to the clients, try to understand their concerns. And if KPPLHAV could not be reached over phone or could not be reached in spite of all the efforts by the ART staff, then this list will be shared with the care and support center and TI, and under the DAPCU supervision, this can be divided among the care and support center TI staff or the link worker scheme staff, whosoever is like available for the particular geography. And then this outreach activity can be planned by that particular organization. And this need to be like done on the weekly basis, and feedback may be shared or discussed during the monthly meetings at DAPCO. So as we discussed, like it's a shared responsibility. Everyone need to work for the betterment of the KPPL-HIVs. So for that, it will be like needed, like at TI center, they may be sensitized about the key population group, their counseling needs and everything, but they may not be like aware of the importance of ART, how to like pass the right message about the ART initiation and the adherence, or the benefit of retention, and how to track lost to follow-up clients, and what messages need to be shared with them about the importance of follow-up viral load testing and viral load suppression, U is equal to U. So those messages they may need to know. So for that, ART center staff may take this responsibility of sensitizing TI staff, maybe by conducting regular sessions at TI centers, or maybe through the virtual, or maybe during their monthly coordination meetings. These sensitizations can be initiated by ART center. And other thing is, like we were discussing about, the accompanied referral will be needed from TI. So they need to understand what is the importance of accompanied referral. So that importance need to be shared with them, so that they are like well on board, like, okay, I am accompanying this person. It's not like my duty or some additional duty is given to me, that's why I am accompanying. But this is actually for the betterment of the program, in larger interest of the program and the client. That's why I am accompanying. It will otherwise benefit the person if I accompany the client. And similarly, at the ART center, as I discussed, like sometimes clients may feel uncomfortable while waiting in the public health facility or at ART center. So they may need to be like sensitized on the gender, sexuality of different key population group. Special counseling skills may be needed for them for different key population groups. And disclosure may be a challenge, like which AP group, how to disclose the status with them. So those things will be needed, and you can use the virtual platform or a physical training sort of can be planned for orienting ART staff, maybe TI staff, or the like TSU staff from the state level can take this responsibility and sensitize all the ART center staff. Similarly, we can use some sort of IC material within the at ART center. Like if in the waiting area of ART center, if you have some sort of material specific for a different key population, like some material on female sex workers, some material for the MSM or PGs or IDUs, so that people feel like this facility is key population friendly, and they feel like comfortable sitting in that waiting area. While they are waiting in the at the ART center, just by looking at these posters, they will feel like, okay, this facility is quite sensitized towards the key population group, and they will feel comfortable in sitting there. So that sort of material can be displayed in the ART center waiting area. At the same time, you can display contact details of organization, support system. You need to identify different support systems available for the key population group. Like there may be some NGO working in the field of like for social protection, or some sort of offering some sort of support for getting their social entitlement or social benefit of key population group. These are like different states have different type of social schemes which are applicable for the different key population groups. So those we need to understand and provide the details of the schemes which are like applicable to the anyone. Similarly, there may be some NGOs who are working in the field for providing some sort of legal support, or some sort of support in terms of like handling their financial or other issues. So that sort of help also we should know, so that during the counseling session, if something is coming up, we should be in the position to like inform or guide the person about the support where it is like available within our district. Then like comprehensive prevention package services need to be provided through the IRT center and TIA, both the facilities. So counselors shall like reinforce on these comprehensive prevention services like condom promotion, condom demo, distribution. Box must be kept at an appropriate place for free pickup from the IRT center or within the hospital premises. We can discuss about the safe injection practices, and we can link them with the site from where the safe injection and needles can be taken. These are some key indicators which need to be reported by the TI NGO to the SACs and monthly basis, like number of KPPL-HIV navigated to the IRT center out of total positive registered at TI or the partner NGO. Then out of them, number initiated on ART, number retained on ART after 12 or 24 months of ART, number eligible for viral load testing, and number tested for viral. These are the basic indicators for all the 395. Now we will touch base on the other vulnerable population groups like PLHIV in prison or other closed settings. So we know like prisons have their own challenges due to several operational issues, like security personnel were not available, vehicle was not available for bringing PLHIV to the IRT center, or there were some other concerns within prison itself. So prison authorities were not aware of the PLHIV status of HIV positive status of the PLHIV. There were like concerns of like testing facility not available within the prison. So people were not linked. So there may be many issues. Under trials are not being like not having access to the healthcare facilities set up within the prison. So we need to understand like all, even if it is a convict or under trial, we need to understand both have their like importance of getting themselves tested for HIV and if found positive to be linked for the ART services. So we need to find a way how we can provide these services within the prisons. So there may be like 2-3 different strategies. Like if person is not on ART and there is a medical officer appointed in the prison hospital, we can designate that hospital or that medical officer for providing ART. We can train them and start ART as per the rapid ART algorithm. They can initiate ART after getting some baseline investigation samples. If that is not possible, then ART initiation can be think of like at ART center by sending HIV positive prisoners to the nearest ICTC facility. And if they are already on ART, then we can plan for the establishment of link ART center within prison, so that the staff working in the prison hospital can be like trained on SOPs for link ART center. And patient, if that is not possible, then again we can think of like development of sort of community level dispensation, sort of community ART refill group type thing, differential service delivery sort of model within the prison. If that is also not possible, then or the medical officer is not available within prison, then person can be linked to the IRT center, and stable unstable criteria may be followed, and 6 months medicine can be dispensed. And once in a 6 months, they can be seen at ART center for clinical and laboratory monitoring. Now the other challenge with the prison inmates is like, we may not be having any idea about specifically for the under trials when they will be released, where they will be going, if we are not having this information handy with us. So we may be having like information of how many PLHIV are there in our district prison, but we may not be having information from where they are actually coming, what is their place of like residence. So where they will be like going, if tomorrow they may be transferred to some other jail, or tomorrow they may be like released on bail, or released because of like completion of their prison period. So but we should be knowing like where they will be going. So for that we may need to sensitize prison authorities and the prison inmates both, so that people should be made aware of like ART need to be continued even after release from the prison. So for that we may need to know their whereabouts, where they will be going after release from the prison. Prison authority must be having this information with them. So if we can develop sort of coordination mechanism with them, and the line list can be shared, on weekly or monthly basis from prison, like, okay, these many people are like released and they are now at this place. So we can develop sort of coordination with the ART center of that place, and then mechanism of transfer out can be established so that person can continue their ART without any disruption of services. Now coming to the other important population group, that is migrant and mobile population. As Dr. Purnima was mentioning, like migrant people are having their own challenges because they are frequently migrating from one place to other. It may be like temporary migration, it may be like permanent migration, it may be like family migration, or it may be a single migration. So we need to understand dynamics linked with the migration. It is very important to understand something known as space of vulnerability, like the conditions associated with the migration, not only the what we call the movement of the migration. We need to understand the conditions associated with the migration which make them vulnerable for getting infection. So those things need to be understood, and based on this information, we can you can identify from your, like at ART center, if you analyze your data of last 2-3 years, you will be able to understand, okay, these many this particular age group people, or the people referred from this particular TI, or people from this particular work profile are like prone to migration. So that sort of like idea you will get from your database, and you can identify people with potential of migration. So accordingly, you can plan for, like in some geography there is a tradition like delivery will happen in the parental place, not at the in-laws place. So that is also a potential migrant client. If someone is pregnant and in that particular geography, the pregnant woman is a potential migrant client. So we need to understand their current contact detail and their parental home address and details also. We need to provide them information about the nearest ART services to their parental home. So that sort of vigilance is needed. And apart from that, if someone is like some factory, you have industrial or factory area in your geography. So there may be people working in those industries which are like coming from other geographies or other states. So we need to understand their concerns, their residential, like where they are residing in your city, and from where they actually belong, or their permanent address, source and destination place addresses. Those need to be like understand, and we should try to get more and more information on that. And I think TI, ICTC, ART, if all work in as a team, they will be like in a better position to get more information about the people. So we need to plan our counseling accordingly. Focused counseling need to be provided. We need to provide them information about, one thing is very important thing is 1097, that is a national helpline number, and they can avail this services from this helpline at any time. They can simply call at 1097, which is a toll-free number. They can simply call this number and try to get an idea. Okay, I'm in XYZ place, and I just want to know where the ART center is from my current location. Please tell me the nearest ART center. Helpline people will be like able to support these clients. Also, if we are knowing about their permanent residence, their source and destination places, we will be in the position at ART center to help them to understand the nearest testing and treatment facilities of their place of residence. So that sort of coordination mechanism need to be developed, and transfer out should be seamless. Like it should be planned well in advance. If person is like sharing details of transfer, detail of migration. If sometime client reaches at a ART center without informing the parent ART center and just working at the different ART center and telling like I was registered with so and so ART center, but I do not have any record of them. In that case also we can provide some sort of medicines to them as a stopgap measure, and these patients can be termed as in transit transmission within SOCH, and the medicine can be provided from the recipient center. So now coming to the HIV positive pregnant women, like I was mentioning about, there may be a like migration factor linked with this, and there may be other concerns, because in the last trimester pregnant woman was not able to come at ART center, how to do their testing, how to initiate ART, how to continue their adherence, maintain their adherence. Those concerns can be dealt with under the DAPU and SEX guidance at ART center level. You can devise your own mechanism for dealing with these sort of concerns. And we need to make women aware of importance of initiating ART early during the first trimester only. That will actually help them in preventing vertical transmission to their baby. So the rapid ART, same day ART can also be think of and can be provided to the pregnant woman. So they can be fast tracked for the service delivery. And if husband and wife both are positive, if their children are also identified as positive, so we can provide a family-centric approach. If it is a pregnant woman, then we can provide ANC-centric approach, like ANC is given priority or fast track, or maybe a counselor is dedicated for the ANC or family counseling only. So that sort of mechanism we can develop at our center. And coordination is important between ICTC and ART center as far as index testing, partner testing, or family testing is concerned. It may not be job of only ICTC or the only ART center. It's a shared responsibility. Some of the work can be done at ICTC, like contact illustration can be done at ICTC, but if a person is not comfortable in sharing contact detail or family member detail, but that in that case, that can be done at ART center as well. We need to promote for the institutional deliveries of all the HIV infected pregnant women and offer them other care and treatment services for the associated conditions like RTA, STI treatment, TB, or any other OIs. Similarly, we need to provide them counseling on the exclusive breastfeeding or the replacement feeding, whatever is the choice, regarding the early infant diagnosis, ARV prophylaxis, then routine healthcare services for the child, infant, specifically immunization, CPT initiation, then TB prevention treatment initiation. Now, one more important point here is ANM and ASHA workers, they are working in field under National Health Mission, and they have their mandate of reaching out to each and every pregnant woman. So because of their job responsibility, they may be in contact with the pregnant woman, and it may happen the pregnancy was detected first and then the testing was done and the person turned out positive. So ANM and ASHA workers may be knowing about the HIV positive status of those pregnant women, those who are actually registered with them as an antenatal. So it's quite possible. So here it's the responsibility of ICTC and ART center and the care and support center staff to make ANM and ASHA sensitized enough for taking care of confidentiality of the HIV positive pregnant woman, so that ASHA or ANM, being the person in village, it may not be they have all the right to disclose the status. It should not be like that. So their status need to be keep confidential, even if they the ANM and ASHA belong to the same village from where the pregnant woman is. And that sort of confidence need to be given to the pregnant woman. Your status will not be disclosed by anyone, even if it is ANM or ASHA who is knowing your status. That is for sure. That sort of confidence need to be given. Then only pregnant women will feel comfortable in reaching out to ANM or ASHA in case of emergency. ART and care and support center staff may not be in position to offer emergency support in case of labor pain or something. ANM and ASHA, being there in the village, will be the first point of contact for the pregnant woman. But if the pregnant woman is not feeling confident enough for reaching out to them, just because of the issue of confidentiality, then it may affect their outcome of the labor. So that we need to understand and sensitize people linked with these services, so that there should not be any harm to the client. And ART center and ICTC may work in close coordination, specifically for the people, those who are like women presenting directly in labor at the ART center. Now coming to the dolutegravir, you all knows, it's a great drug actually. It has a superior virological efficacy, is well tolerated, having very minimum side effects, quickly suppresses viral load, having very high barrier to very high level of barrier to the resistance. People may not get resistance that easily with the dolutegravir. So and it reduces the chance of transmission of HIV to the baby and other sexual partners as well. And based on the latest evidence, we understand like there are very, very minimum like neural defects as compared to the previously anticipated or previously available evidences. So the benefits are outweigh the risk attached with the dolutegravir. This information need to be shared very clearly with the HIV positive women, so that they should make their own decision of choosing dolutegravir or non-dolutegravir based regime, because the benefits are significantly high, and it will prevent with absolutely like very, very minimum or risk of like transmission to of HIV to the child. So those need to be like discussed in detail, and the appropriate information need to be provided. Based on that, a woman can take their own decision. The other important points related to dolutegravir is like women who are already on DTG based regime and identified as pregnant, there is no need to worry at all. We can continue with the DTG based regime and just counsel women about there is no harm in continuing DTG, and it is otherwise going to support them in preventing HIV transmission. Secondly, all the newly diagnosed pregnant women, irrespective of their duration of pregnancy, if they are already identified as pregnant, they can be initiated on DTG. There is no issue in that. And third important thing is the women who are not pregnant and are not on DTG based regime, who are currently pregnant and not on DTG based regime, on any other ART regime, ideally we should take initiatives to shift them on DTG based regime as early as possible. Now coming to the components of care for the HIV exposed infants. So HIV exposed infants are at risk of getting HIV infection. So the counseling about the exclusive breastfeeding up to 6 months, avoiding mixed feeding, continue breastfeeding till 2 years of age with complementary feeding, ARV prophylaxis, then early infant diagnosis testing from 6 weeks of age, HIV confirmation testing at 18 months or 3 months after stopping breastfeeding, and CPT from initiation from the age of 6 weeks, TB preventive therapy, immunization, vitamin A. All this information need to be shared with the mother or the caregiver of the infant, so that the timely interventions can be taken, and actually the infant gets all these benefits from the healthcare facilities. And apart from that, growth and nutritional evolution is also very important to maintain the growth chart at ART centers, just to pick up malnutrition at the earliest point. And malnutrition is a sign of like failing regime. So if we are like able to pick up malnutrition at early point, we will be like able to pick up the failure and switch the regime at the earliest possible time, so that we can prevent accumulation of TAMs and resistance to the next regime in a child. So while we are providing care to the children with HIV, we need to understand that there are different components which are like essential for their care. Apart from like early identification of positive pregnant women, early infant diagnosis, as we discussed in previous slide, index testing, rapid ART initiation, there is a need of like counseling to the caregiver, right time of disclosure to the child, then appropriate information, appropriate like guidance about the nutritive food, how to maintain their nutritional status, how to monitor their growth and development, importance of immunization, vitamin A, TB prevention therapy, management of advanced HIV disease, and monitoring for their retention. Those things need to be like carefully monitored, and repeatedly these information need to be provided during the counseling sessions. Parents are actually worried about the health status of their children. Sometimes they, because of this worry only, they are like not get ready easily for giving medicine to the children, because they feel like medicines will do more harm than benefit to my child. So that apprehension need to be removed. We need to counsel them properly about the importance of ART, safety of the ART drugs for the children. Sometimes they may feel like how to give this medicine to my child, the quantity and the measurements, how I'm going to take that. So that may sometimes we need to like do the hand holding for making them understand like what is the right dose for your child and how it can be given. So those are the and then they are also worried about the nutritional status. They will ask you questions like any particular advice for the nutrition, what type of food can be given or what needs to be avoided. And believe me, if as a doctor you are saying nothing, you can give whatever you want to, people will feel like it's not a good doctor. So ideally, we should give some advice for the nutritional status, even if it is a child or the adult or whosoever it is. So we should be having some, specifically during this COVID challenges, people are coming to the healthcare facility to the doctors for asking about the advice for the nutritional improvement in immune status and improvement in the nutritional status of the person. So we need to like understand these concerns and we need to provide an appropriate advice for that, so that people should not feel like nothing is said and like doctors are not hearing us properly and not giving us time. That should not be the case. So when we are like designing our counseling for the child, we need to understand the concerns, like we need to understand age appropriate language which need to be used with the child. Sometimes non-verbal communication with the children is very important for making children comfortable sitting in the hospital. And appropriate feeling of expression, like feeling and appropriate language use. Maybe you can use some sort of interactive tools in your ART center. You can have a corner where you have some drawings or storytelling or some sort of material is placed over there where you can like doing drawing or like playing. You can discuss with them about their health needs and the need of disclosure. Like the age need to be understand like at what age we are going to disclose HIV status of the child. So we will discuss a bit about disclosure in the subsequent slides, and we need to focus on child's need, both physical and psychological. Sometimes children are having children are very conscious about their physical and psychological development. They may ask multiple questions: why my friend is behaving like this? Why my friend is not going to take medicine? Why I need to visit at a hospital at every month? So they may have a lot of questions. So those we need to be like handling very carefully and try to provide information to the children so that we can address all their concerns. So before child, we need to prepare the caregiver, be it the parent or the grandparents or any other caregiver or relatives. We need to prepare them also. Like as I said, like they may be apprehensive about the adverse effect associated with the ART medicine because it's a long-term medicine. Daily child has to take some drugs, so it may be having some sort of adverse effects on their child. So that need to be like shared with them, like that there is no harm associated with the medicine, or what type of like it may be like nausea or headache or abdominal discomfort. These things can happen in the initial stage, and that will simply go over the time, and there is no need of like doing anything for that. Just reassure them. You may need to ask on each and every visit about these things. Has your child feel like this thing, or what is the condition now? Is it like gone or is it still there? Or if it is like continued, you may need to get the consultation from the pediatrician or some other expert like ART medical officer also for change in the medicine or some addition of some medicines for their minor ailments. But important thing is the caregiver need to understand importance of giving medicine regularly at the fixed time on daily basis, the importance of treatment adherence, and like taking the responsibility of giving medicine in his or her direct observation. Why this needs to be given in direct observation? Why drugs need to be stored at appropriate place out of reach of the child? Those things need to be discussed in detail with the caregiver, so that child and caregiver is like able to maintain the adherence of the child, and child is doing well with the medicines. So there are different ways how you can encourage children for maintaining adherence, like coloring books or My ART calendar, which was like published by NACO. And if children are not knowing about the HIV or AIDS, there is no need to use these words in front of children. Just avoid using HIV and AIDS word in front of them, because it's an internet era, and children can go to Google and simply search for HIV or AIDS word if they are like not having sufficient information on this. So it will be better to avoid if children are not knowing about this age, and the explanation should be age appropriate. At the right time, we can disclose it slowly and gradually. Otherwise, we can use other terms like germs or like enemy or something like that. And disclosure, it may not be like abrupt disclosure. It should be like gradual over the time, age appropriate disclosure. And with the caregiver or without the caregiver, there may be some different counseling sessions with the children. Assess level of adherence and issues of child and the parent or caregiver, and give them appropriate solution to their concerns and issues. If it is a family who is like HIV positive, then we can go for the family centering approach. Give them a due date for all of family members for pill pickup. We can align these dates with the immunization schedule as well. And if the children are like having poor adherence or having unsuppressed viral load, so we may need support from the field level staff like care and support center or other NGOs working in this field. Like I said, like disclosure is a complex process. It may not be done over time or abruptly. It should be like before disclosing, we need to understand few important points like psychological distress or what are the likelihood of disclosure, and how we can like engage them, and what may be the appropriate time and of age and where we can like disclose. It's usually like during the 6 to 9 year of age we can do the partial disclosure, and more than 10 year of age you can do the like 10 to 12 year of age you can do the full disclosure. It is recommended that less than 5 years we should avoid disclosing, but we can prepare caregivers for disclosure by partial disclosure by 6 to 9 years. This is an annexure given in the operational guideline, where detailed stepwise guidance is provided for disclosure, partial and full disclosure. For 6 to 9 year age, you can do the partial disclosure, and during 10 to 12 year age, you can do the full disclosure. How it can be done, what are the messages which we can use during partial disclosure and during full disclosure. This is given in detail in the guideline. You can go to the guideline and just print this annexure 14 and keep it at the counselor's table. That will also help you. So, so basically, counselor to support the caregiver for disclosing. So there are two like paths. Like left side, you will see the stepwise guidance for disclosing partial disclosure for 6 to 9 year of age child only with the caregiver. But we will be going to discuss with the caregiver for this particular age group child during the partial disclosure. The left side is the stepwise guidance for the caregivers, and right side is the guidance for the caregiver and child both. So if we go with the left side steps, like first you can ask simply caregiver about the reasons for coming to the clinic and taking treatment, explain the partial disclosure, and here you may not need to like name HIV, explain the advantages of the disclosure, then timing when to disclose, how much to disclose, and just try to understand from caregiver perspective about the barriers to disclosure. And then with the child and caregiver, you can like understand, you may want to use some different term like germs in the body, sleeping germs, and medicines as a soldier, our immune system as a soldier, and we are providing additional army soldier like medicine as a additional army for fighting with the sleeping germs. So taking treatment every day to keep the sleeping germ asleep. So those terms you can use, and medicines can be termed as a good night medicine. So the detailed step-by-step guidance is there. I'm not going in much detail of that. You can take a printout of this annexure form guideline, or just go ahead with this annexure for your counseling session. Similarly, there are step-by-step guidance for the full disclosure as well, like for the only for the caregiver and for the child and caregiver both after the age of 10 years. So this is the step-by-step guidance as we discussed for the partial. Same way, there is a step-by-step guidance for the full disclosure. Now, this is important. We are talking about this since many years. Like HIV is no more a death sentence. It's like chronic manageable disease as good as diabetes and hypertension. But we people working in HIV field are knowing this very well. But I think there is a gap in level of understanding at general public level. So we need to work on this message. We need to share this message with people as much as possible. We can make some posters and put it in your ART waiting hall. Like ART, HIV is not a no more a death sentence. It's a chronic manageable disease. You can like live your life long with just one pill a day. So like that, you can use different type of posters which can be displayed in your ART center, in your hospital, so that people should be made aware of the HIV medicines. And we should also understand like their own challenges of day-to-day life, like how that like daily medicine need to be like factored into their into their day-to-day life. And the second most important thing is we need to make people aware of like why monthly visits are important. They should not be taking this impression after visiting a ART center. Sometimes people feel like it's not for us. It's basically for filling up their records. That's why we are visiting. So they may feel like that because when a client visited at ART center, we were busy in like filling up of green book and white cards and dispensing the medicine, filling up in source, and we were actually not at all looking at the client. So they feel like that. Like it's not for us, it's actually for them, it's for the staff because they need to fill up some records. The visit is actually for this only. So then they will come up like, okay, I will not come. Someone will come on my behalf and will get the medicine. If that is happening on a regular basis, it should not be promoted. And we need to understand, like people should be like given this realization, like, okay, this visit is important. Why I need to visit the ART center? That is, there is something which they are going to do, and there is something which they are going to examine or something, some information they are going to give us, some like clinical examination, laboratory examination, counseling. Some work need to be happen. That's why I need to visit this facility. So that sort of impression should be given to them. So try to work with the caregivers and the children and try to give them this importance of their visit. And if it is like not possible for them, we can think of differential service delivery. We can think of MMD if they are fitting into the criteria of MMD. We can always explore those possibilities. But do not give impression of like visits are just for filling up the records, not for the clinical or any laboratory examination. So nutrition is very important. As we said, like malnutrition is an early sign of the failure of the medicine. So we need to look into that. We need to provide enough information about the nutritious diet, and maybe for the infant we can say like exclusive breastfeeding during first 6 months, and then mixed feeding maybe to be avoided, and complementary feeding need to be started at appropriate age. With the continued breastfeeding, maybe after the 6 months up to the 2 year of age. For children more than 2 years, appropriate nutritious diet need to be given. So that information need to be shared. And each and every visit for children, we need to measure weight, height in case of children up to 2 years of age, plotting of weight for height or height for age chart in white card. That is very important actually. And most of the center, I believe most of the center, we are missing plotting this chart in the white card, because this is the only tool with us which help us in identifying malnutrition at the earliest time. If we are plotting this chart, we will be like able to identify malnutrition at the earliest point. Mid-arm circumference. I don't know how many ART centers are monitoring this thing. Mid-upper arm circumference. Are they doing it regularly or not? Identifying child at risk of malnutrition. This needs to be done on regular basis. then only people will be confident enough, like I need to take my child with during the visit at ART center, because it is important for him or her actually, because something is going to happen with him, because they are going to measure weight, they are going to do the mid-arm circumference, they are going to do some clinical examination, they are going to ask something which we need to like discuss with them, and that's why my child need to visit the center. If it is not possible, I'm saying if it is not possible for the family, we can always explore other possible solutions like differential service delivery or multi-month dispensation, if that is like possible and eligible, if the clients are eligible for that. And but apart from this weight, height, and this thing, developmental assessment like gross motor, fine motor, language, social skills, these are also the different sort of milestones which need to be like assessed during the visit. These are the vaccines which need to be given according to national immunization schedule. I'm not going in detail of these vaccines, but all the vaccines under national immunization schedule need to be given to the children as per their age. Like BCG at birth need to be offered to everyone, but if the child is like severely immunocompromised, we can avoid giving at birth, and maybe if it was not given at birth, we can delay it if the child is severely immunocompromised. But if it was given at birth, there is no worry about that. If it was not given because of any reason and child is severely immunocompromised, we can delay BCG vaccine. So CPT prophylaxis is an effective and proven strategy to reduce morbidity and mortality. So we can give cotrimoxazole prophylaxis to all the children, like up to 5 years of age, irrespective of WHO stage or CD4 count. But if it is more than 5 years of age, then we should look into the CD4 count and WHO stage. If it is WHO stage 3 or 4, regardless of CD4 count, we can give. But if it is stage 1 or 2, then we need to look into the CD4 count. If it is less than 350, we will be giving CPT. Then other important therapies like TB prevention treatment, which need to be given, like for all the children living with HIV. After ruling out active TB disease, we need to give isoniazid for 6 months. If a baby is born to a microbiologically confirmed TB mother, we need to first assess this child for the active TB and try to rule out TB with a battery of tests. And if child is negative for active TB, we can give TPT for 6 months. And infants with HIV having less than 12 months of age who are in contact with a person with TB or unlikely to have active TB should receive TB treatment, TB preventive treatment. All children with TPT should also be consulted on the adherence for TPT and adverse effects. Forest screening need to be done on each and every visit to exclude the active TB. And if child is presented with the TB symptoms, we need to evaluate for TB and other drugs that will be tested. Now coming to the advanced HIV disease management. So we need to screen child for OI and then treat for OI in malnutrition, provide prophylaxis or preventive therapy, and consider for the rapid ART initiation or treatment for the serious OIs, and provide child-centered counseling. These are the some key indicators which need to be monitored. Like I will recommend to keep this chart printed at the table of medical officer, staff nurse, and the counselors. Like some of the it's a joint responsibility. It's not the one person's task. Like interim medical history, growth nutrition, physical examination, developmental progress, forest screening, T-staging, lab report testing, adherence to ART. So these had to be done by the medical officer. But some of the things can be done by the staff nurse as well. Some of the things can be done by the counselor, like calculating ART dose, checking for adherence, concomitant medication checking. So those things can be done by the counselor as well. So I will suggest to keep this chart printed at everyone's table and just look at like these are the things which we are going to do at each and every visit, and make people comfortable in like visiting the facility in as a child-friendly hospital. So there are different package of services under differentiated services. Like we need to understand enablers for the adherence and retention to the ART. What is going to like benefit the child? if we can like schedule our appointments of children at the health facility in a way like their school may not be like interrupted, their classes will continue. They can come in the evening hours or early morning hours. They can collect their medicine from differentiated service delivery, community-based sites, or if they are like coming for immunization, if they are coming for the pediatrician consultation, or if the family is coming, we can coordinate and give them appropriate dates which are aligned with the family. Or if there is a holiday in the school, then we can give them appointment according to their school calendar. So various like options we can think of, and it may be like person to person. We can give different options. Like if there is a like afternoon break in the school, we can give medicines. We can schedule their appointment during those hours. If it is like early morning school, they can come in the evening hours. We can schedule their appointment in evening. So lot of options can be planned based on the personal choices. And the important thing is now, previously there were no such definition for the stable children. So now there is a definition for children to be like termed as stable for more than 2 years of age, if they are on ART for at least 6 months, having viral or suppressed adherence more than 95% in each of the last 3 months, are on the same regime without any change in the dose or formulation for last 3 months, with no current illness or no any medical condition like malnutrition is also not there. We can consider this as stable. And I think the session is taken on different package of services under differentiated package service delivery, like package B and C. So for stable children, we can provide package B, and for unstable children, they may need like extra care, so they will be provided package C. I'm not going in the details of package. I believe that is being taken care in the previous session. So now coming to the adolescents. So adolescents are like age group 10 to 19. I think I'm little over the time. We'll try to complete it next 5 or 10 minutes more. Please bear with me. So adolescents are having their own challenges because they feel they are like educated enough. They feel they have a very good tool in their hand, that is known as the smartphone with Google in that. So before reaching out to the doctor, before reaching out to the parent, before reaching out to anyone, they will reach out to the Google. And second area of priority for their guidance and for their consultation is their peer. So once they exhaust Google and peer group, then only they will reach out to anyone else. So that is how adolescents nowadays behave. So we need to understand their concerns also, and we need to understand their questions also. We need to answer them appropriately for their whatever concerns, whatever issues they have. It may be from Google or from peer, but we need to understand and provide appropriate solution to them. Otherwise, they will believe more on them only, not on us, if we are not able to like provide solution to their issues. So adolescents with HIV may be two different groups, like one children who are like living with HIV and transition to adolescent, and those who acquire infection during the adolescent period. So because of this, what I was saying, like because of different apprehensions, different issues, challenges, and beliefs of adolescent group, they have all the good reasons for believing for not to take medicine regularly. So they will be like having some optimum adherence. So we need to understand their concerns and plan our counseling sessions accordingly. Include those questions and answer to those questions or solution to their problems during their counseling sessions. Maybe they need some mental health support. Maybe they need some sort of partial disclosure related counseling. They may be apprehensive about the HIV and AIDS. We need to take care of those things and need to provide them information on that as much as like possible according to their age. And we need to be like non-judgmental, and the facility should be like adolescent friendly facility. So they should be feeling like coming to the peer, not to the someone at a different age group with them. So counselor should be in a position to foster relationship with the adolescent and making balance with them, so that they can feel comfortable in discussing with the counselor. And maybe you can spend some time with them, try to understand their concerns, make them confident in sharing their views and their challenges. And if they are like transitioning to adult, they may have other challenges as well. So those things we need to like discuss in detail. If they are from the key population group, then their challenges may be like apart from the adolescent age group related challenges, they may have challenges related to that particular key population group as well. So we need to understand those things also and provide appropriate solution to according to the individual. So as I discussed, like we need to provide age appropriate counseling, and we need to make them realize like this facility is adolescent friendly facility, and we are there to support them and try to understand their concerns. It may be like sexual concern, it may be like life skill related issues, it may be like education related issues, it may be psychosocial issues, physical growth issues. So we need to understand all the concerns and provide appropriate counseling services to the adolescents and their caregivers as well. Maybe we need to link them with the care and support center or community-based organizations or NGOs working in this particular field. And like I discussed during the children's session also, for adolescents also we can plan for the schedule, like calendar, school calendar. Accordingly, we can plan their appointments. If there is a holiday, we can plan their appointment on those holidays, or according to the school time, college time. Or if they are stable, we can give them MMD or the community-based refill group or community-based Linkiati center. It can be family-centric. And it will be good to identify, like if you are having, say for example, if you are having 10, 15 adolescents taking medicine from your center, there may be one person who is like having a leadership skills. You can identify one of the adolescent as a adolescent peer leader, train them, educate them, guide them properly so that they can work as a mentor for other adolescents. And people will listen to him more than you. So it will be good to identify one adolescent from all the adolescents taking medicine from your side, and just work with that particular adolescent and provide enough information to him or her, motivate them to like provide counseling services as a peer mentor to the friends over there. So that will help you in improving adherence of all the adults. So there are different networks like youth clubs, Red Ribbon clubs, National Service Scheme, National Cadet Corps, Indian Red Cross clubs. There are different groups which are working for adolescents. We have to identify these groups, leverage the support provided by them. There are different agencies working in the field of like orphan and vulnerable children. There are orphanage homes, child care homes, NGOs working for the street children. So we need to identify these organizations and work in close association with them for the betterment of the adolescents. These are the like programs, existing programs for the national government, like RKSK, Kishore Shakti Yojana, Rashtriya Yuva Shaktikiran Karyagram, RYSK. These are the different programs run by the national government. We need to understand these programs in detail and what are the services provided by these under these programs, and how we can link our adolescents living with HIV with these programs so that they can take benefit of whatever services being offered under these programs. I think this is my last slide. Thank you. Thank you, everyone. So I know I'm a bit late. If there are any questions, we can take those.
Yes, sir. Participants can now unmute their mic and ask questions.
Hello, am I audible?
Yes, ma'am.
I am Dr. Priyanka from Andaman Islands. Sir, it was a great presentation. Thank you. I had a certain concern. Actually, recently I got a patient who was 15 months old, and his mother was diagnosed at some other state, and she just brought the child here for visiting. And they gave a history of repeated hospitalization in the child. The child was frequently getting sick and was malnourished also. And the DBS was reactive on certain occasions, but the child was not started on medicines because they kept on telling the parents that the confirmation will be after 18 months. So I understand that the diagnosis can only be confirmed after 18 months, but should that mean that the patient is not started on the medications if there are all the indications? Hello?
Sudhir sir, can you please unmute your
Oh,
mic?
I'm sorry. I'm sorry. I was speaking with mute. So I will say, Dr. Priya, thank you very much for bringing this up. It's an excellent question. So, it's a clear classic example of the communication gap. It's not like that. Like if a person is like not of 18-month age, we are not going to start ART. It's like at the EID testing, like at the DBS test result only, with the 2 DBS positive, we are going to start the child at as early as possible on ART. Even in fact, we are saying that rapid ART initiation is most important for the children and the pregnant women. So we need to consider for that. We need to consider ART initiation for this child. So if the child is not yet started on ART, I will suggest you to look for the any active OI, treat appropriately if there is any major OI which need to be treated before initiating ART. Otherwise, just simply go ahead with the initiation of ART. So it's already too much delayed. So do not waste more time on that. Just start ART.
Yes, sir. Thank you. We've started the ART, but I wanted to give the suggestion that if this message can be conveyed to everybody, to not wait for 18 months.
Yeah, very right, very right. This message need to be conveyed to each and every place, each and every ART center. Like it's not like we are going to wait for 18 months for ART initiation.
Yeah. Thank you, sir.
So thank you for bringing that up. Thank you very much.
So we have a question in the chat box. Cotrimoxazole is not available at the hospital. It is not regularly available outside either. Any comments on this?
You need to explore with SACs for that, or the alternate medicines which can be given in place of CPT if that is available. So maybe other states, if they are having, you can work with them. I think Depsone can be given in place of CPT. If you have that, you can explore for that as well.
Is TLD drug?
So Dr. Sudhir, if I may come in there.
Yeah, Dr. Reshu, thank you.
So
I was not aware like you are there.
It's not. So basically, like I think if you do like mass procurements, then the drug would be available, though it is not at times not available in open market. Work on quantification of the CPT requirement for your state, and either from NACB funds or through NHM, you should explore the possibilities of procuring it more centrally. Thank you.
Thank you, Dr. Reshu.
The next question is TLD the drug of choice in women who wants to conceive? What is the alternative?
Again, what is
TLD? Is TLD the drug of choice in women who want to conceive? What is the alternative? What is the other alternative otherwise?
If she is not willing to take TLD, is it the question?
Is that the only drug of choice? Is there an alternative?
Yes, as I said, like TLD is like benefit are like outweighing the harm about because of DTG. So we discussed this thing, like DTG is a good drug for many reasons, like less side effects and having the good like viral suppression rates and all those things. And the neural tube defect, which was like previously we were thinking of like having more neural tube defect, but that is not the case now. So we know like benefits are more as compared to the harms with the DTG. So we need to give this information to the woman and make her like on her own decision for taking medicine. It may be like if TLD, if she's already pregnant, then there's no issue. You can continue with the TLD. If she is not willing to take TLD and she is planning for conceive, then there are alternative options like TLE is there, so you can give TLE if she is like going with that. But ideally, you should like counsel her and provide the information appropriately so that they can take informed decision about the benefit of, like, the most important benefit is prevention of vertical transmission with the TLD because of suppression in viral load.
The next question is, if a 10 months baby is on breastfeed and diagnosed antibody positive after diagnosis of mother as HIV positive, can the 10 months baby be given prophylaxis syrup nevirapine?
Dr. Reshu, do you want to answer that?
Is the child still breastfed?
It's given the 10-month child is on breastfeeding, ma'am.
Yeah, I think it is better to do an antibody test in this case first.
Okay.
And then take a decision. So
Yeah.
if the child is already reactive, then in that case, the full-fledged ART would be required.
Right. They have given the 10 months baby is breastfed and diagnosed antibody positive after the mother has been diagnosed positive.
So antibody positive now. So
yes.
this child should be getting full-fledged ART.
Yeah.
Okay, ma'am. Any other questions? Participants
And ART should be initiated as soon as possible in this case.
Yes.
Any other questions? Participants can now unmute their mics.
Dr. Reshu, I had a question from one of the previous sessions. Actually, can I ask that, or should I restrain to the current topic?
Quickly, if you want to ask, you can.
Ma'am, actually, here we have some many times, but because it was so specific to the place, I was told that I'll be reverted back to later, but I never got an answer. So there we have like prisoners here, and when they are transferred out, like there is no confirmation because they go to Burma and then we have no confirmation or no way to follow up. So they they are recorded as lost to follow up, which is actually, I mean, incorrect. So is there a way to tackle that?
So especially when it comes to, like, sort of a migration outside the country, it is really very tricky and there is no way to get confirmation in such cases. So either in such cases, like, I mean, see, when we say transferred out, it is technically applicable within the ART centers in the country.
Right.
But if somebody is going out, like, out of the country, then it is better to, like, then that the patient has shifted to a new country. Does that answer your question?
Yeah, it does. Thank you.
Yeah.
Any more questions? So I don't think there are any more questions.
Great.
Yeah. Thank you, sir. Thank you, ma'am, for the informative session. Thank you to all the participants for patient listening. We'll conclude the session now.
Thank you. Thank you, everyone, for the
Thank you.
participation. Thank you, Dr. Reshu.
Thank you, sir.
Thank you.